A neonate is brought to the emergency department by her parents. She has been crying for the past day and has developed a fever and an erythematous rash. Upon examination, the doctor notices redness of skin and widespread formation of fluid-filled blisters that are thin-walled and easily ruptured. There is no mucosal involvement. The patient is positive for Nikolsky's sign. Skin biopsy microscopy reveals that lesions are intraepidermal. Blood culture and culture of blister fluid are negative. What this could be? What is your most likely diagnosis? What are your differential diagnoses? Why you came up with those differentials or the most likely diagnosis? What is the causative agent here? What is the name of condition? What is the pathogenesis behind this? What is the major virulence factor that is responsible for this? How would you investigate this case to diagnose it? What are the treatment options? How you can prevent this condition? So these are some of the questions which can be asked from this case. So let us start answering them one by one and let us learn the microbiology in a case-based manner. So this condition is Staphylococcal scalded skin syndrome. In neonates, it is also known as Reiter's syndrome, which is the most severe form of it. It is caused by a gram-positive cocci known as Staphylococcus aureus. As we know, the Staphylococcus aureus is a normal flora of skin. Now, let us understand its pathogenesis. So, in newborn or at risk adults, a cut umbilicus in neonate or skin wounds will promote local Staphylococcus aureus epidermal infection. The Staphylococcus aureus releases a toxin known as exfoliative toxin. These are two types of toxins, ETA and ETP, and they spread systemically via blood. This toxin, it targets desmolagen. Desmolagen is keratinocyte in the superficial epidermis that plays a critical role in cell-to-cell adhesion. Due to destruction of this cell, the superficial epidermal cells, they lose contact and the fluid get collected between them, and this gives rise to the blisters. So intraepidermal necrosis and skin will slough off. This will lead to fluid loss leading to dehydration and also create a possibility of secondary infection and sometimes septicemia or sepsis. Skin usually heals in 2 weeks with minimal scarring. However, the mortality rate is 5% in children, but if adults are affected, it can go as up as high in more than 50% of cases. Now, what is this Nikolsky's sign? Nikolsky's sign is a skin finding in which the top layer of skin slip away from the lower layers when rubbed. It is pathognomic for pemphigus, toxic epidermal necrolysis, and this condition, Staphylococcal scalded skin syndrome. This sign basically differentiates intraepidermal blisters from subepidermal blisters. The SSSS, most cases occur in children younger than 2 years old, mostly as outbreaks, especially in nurseries. Why children are at higher risk? Because of their immature renal system, lack of immunity, and absence of maternal antibody in those who are not breastfed especially. Adults, however, rarely develop this syndrome because they have antibodies to this exotoxin. So why do adults develop this disease? It has been seen that cases in adults are typically involves those with either immunosuppression like HIV and AIDS, or having some renal impairment or renal failure, and those with cancer. Patients with renal failure, they are unable to excrete this exotoxin and hence they develop disease. So what are your differential diagnoses? The main important point to differentiate it from other such lesion is to look for mucosal involvement. In Staphylococcal Aldelson syndrome, there is actually or typically no mucosal involvement, while that is the case with all other conditions which simulates it, like scarlet fever, toxic shock syndrome, toxic epidermal necrolysis, even Stevenson-Johnson syndrome, and pemphigus. Another difference is that Staphylococcal scalded skin syndrome is intraepidermal, while the topmost differential is toxic epidermal necrolysis, which sloughs off entire epidermis. SSS rash is more tender and exfoliative in nature than the scarlet fever rash caused by Streptococcus. Another condition which can simulate it, and it is also caused by Staphylococcus aureus, is impetigo. But impetigo usually localized to one particular area, while in SSS, because toxin sprayed systemically, you can see a more generalized involvement. To give you a better idea, I have made a flowchart so that we can understand how to approach a case with erythematous blisters rash giving Nikolsky's sign positive and negative. If Nikolsky's sign is positive, as in this case, then you should look for whether this patient has fever or not. If patient has fever, as in this case, then we have usually two possibilities. Either it is Staphylococcal scalded skin syndrome, and it typically affects child and adults who are immunocompromised or having renal failure or malignancy. Or it could be toxic epidermal necrolysis, which typically involves adults. As we have already said that SSS is an intraepidermal lesion, TEN is involving entire epidermis. If Nikolsky's sign is positive and patient is afebrile, it could still be TEN or toxic epidermal necrolysis. If Nikolsky's sign is negative and patient has fever, then you should look for toxic shock syndrome, Kawasaki disease, especially in children with swollen hands, scarlet fever, which typically involves mucosa, as well as it shows skin rash, which simulates sandpaper rash. If patient is Nikolsky sign negative and afebrile, then it could be anaphylaxis, morbid poisoning, or alcohol flush. How to investigate Staphylococcal scalded skin syndrome? If you are suspecting that it could be Staphylococcal scalded skin syndrome, then the topmost differential is toxic epidermal necrolysis, because both are very similar in the pattern. Only difference is mucosal involvement. So we can confirm our suspicion with help of skin biopsy microscopy, which will show that the site of cleavage in skin is superficial. It is intraepidermal, as in SSS, while in TEN the site of cleavage is much deeper in epidermis. We can also go for complete or full blood count and urine analysis to look for features of sepsis. If we suspect that patient is suffering from dehydration, we should also check the serum electrolytes. Blood cultures and cultures of blister fluids, they are typically negative, but however, they should always be obtained. How to treat this condition? Because of extensive skin loss, we are afraid of dehydration. That's why fluid replacement is the key to save the patient. So, if condition is severe, you can also admit the patient and start IV fluids. For skin lesions, we can use emollients and non-adherent dressings. I would like to make a caution that avoid silver sulfadiazine, because it has increased risk of systemic absorption and resulting in toxicity. However, we have to give here systemic antibiotics. There is no role of topical antibiotics. If you think that condition is mild, then you can give oral antibiotics. Otherwise, patient will need IV antibiotics. The antibiotic of choice is usually flucloxacillin. But if you suspect that it is MRSA, that is methicillin-resistant Staphylococcus aureus, and that could be because you have a very high prevalence of community-acquired MRSA in your region, or in your hospital, or in your area, or you have initially tried flucloxacillin and patient did not responded to it, or that means the initial treatment failure cases, then you can suspect that it could be MRSA till culture results are available, but they are usually negative. Then you can choose vancomycin. So it will depend which antibiotic will you choose. But the important thing that I would like to emphasize is that it is very essential to add clindamycin here, because clindamycin is a bacteriostatic agent, but it has an excellent skin penetration and it can treat the staphylococcal skin infections very well. Another advantage is that it being a protein synthesis inhibitor, clindamycin also inhibits production of bacterial toxin, making it a preferred agent for toxin-mediated disease such as staphylococcal scalded skin syndrome. And because it develops resistance with monotherapy very quickly, so to avoid resistance, combination therapy with flucloxacillin or vancomycin is always desirable. Because MRSA or Staphylococcus aureus, it spreads with contact. So if patient is admitted in hospital, to prevent spread to other patients, it is essential that we maintain all the standard precaution with contact precaution as well. And we have to focus mainly on hand hygiene so that we can prevent further spread. I hope you enjoyed this case-based learning of the Staphylococcal scalded skin syndrome. If you like this video, do subscribe to our channel so that when I post new videos, you get regular updates about it. And we will learn microbiology more in a case-based manner now on. Thank you very much for listening. Bye-bye.